Hello everyone. My name is Akane Sano. I'm an assistant professor at Rice EC department. And today we are very excited to have Dr. Swann from Baylor College of Medicine. And today Dr. Mukadaman and I are hosting this seminar. And this seminar is our inaugural seminar for Rice BCA seminar series. And this is based on our collaboration between BCM Department of Psychiatry and Rice EC Department. And before I introduce today's speaker, Dr. Swann, just let me briefly explain the logistics of this seminar. Everyone, you are welcome to put your questions through our Q&A windows. And at the end of the talk, we will open up the floor for questions. And today's speaker, Dr. Alan Swann, is a professor in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine, also VA Medical Center, Houston. And Dr. Swann's research focuses on interactions between long-term and short-term mechanisms in the immediate regulation of behavior, especially regarding mechanism of disease progression and suicidal behavior. And his research has been resulted in over 300 referred publications. With that, please take it away, Dr. Swann.
Okay. Okay, so we'll see what happens. My controls are acting a little funny, but we're talking about suicide and things that regulate its time course and why it is so treacherous. And so this slide has text, which is apparently going to appear on the left whenever I don't expect it to. But you can see this is the number of people who died in the United States in 2015 from suicide, homicide, and motor vehicle accidents. And we have data, of course, from years that are more recent than this. The pattern is about the same. The number of deaths goes up in all three categories, and it's gone up roughly proportionally. So you see that 3 times as many people kill themselves as are murdered. I think that's something that is not widely appreciated in our society. And substantially more people commit suicide than die in automobile accidents, which I think also may seem a little surprising, particularly since a certain number of automobile accidents are probably hidden suicides. So anyway, that's what we have. Suicide, I mean, now, we're looking at COVID and 10 times as many people die from COVID. But basically, suicide is the leading cause of traumatic injury. It's increasing consistently and has been since the turn of the century. Other causes of traumatic injury haven't. They've bounced around. So we're going to talk about why the case. And so here we go, a bunch of things. Number 2 cause of death in people between 10 and 34. So even though the gross suicide rate goes up with age, as a proportion of population is particularly bad in younger people. And then since the turn of the century, it's been going up more in women than it has in men. And it's one of the classic things people say about suicide is that it's commoner in men than in women. But I think that we're having something now that looks like it might be regression to the mean, and that that margin is reducing. And so we're going to talk about what are things that are associated with risk, and at the end we're going to talk a little bit about how to find treatments that might be effective in preventing risk from suicide. And if anybody has any questions, feel free to chime in. So the timing of suicide is a crucial factor in doing something about it. And many risk factors have been identified. Any of us could sit down and list, maybe 6 or 8 characteristics. And that these people with 6 or 8 of these with these 6 or 8 characteristics would have a 50% chance, say, of eventually dying from suicide. So we know about suicide risk factors, but we don't know how to tell when someone's going to commit suicide. That's a problem. So that timing of suicidal behavior results from interactions between long-term characteristics, sometimes things we were born with, sometimes things that happened before we were born, and immediate circumstances that affect action. So then we've already talked about this number 10 cause of death business. And so we're going to be talking about what influences short-term risk for suicide. So a couple of things about it. First, that people who have made a medically severe suicide attempt, a suicide attempt that resulted in injury that could have been fatal or that could have caused long-term harm. These people are at high risk. Their all-cause mortality is substantially higher than it is for other people of their age, gender, and race in the population. And this persists for 5 or 10 years after the attempt. And after that, it kind of fades into noise. Interestingly enough, their post-hospital survival time after they're hospitalized for the injury, no matter whether the suicide attempt was something that was considered premeditated or was considered impulsive, their post-hospital survival time is correlated with impulsivity as a personality trait, like the Barrett impulsivity score. The higher the Barrett impulsivity score, the shorter they live after the hospitalization. As a group, they have very high behavior risk. They are more likely to die from accidents. They are more likely to die from homicide. They are more likely to die from just about anything than people who did not make a medically severe suicide attempt. And so you can see, well, gee whiz, if I can determine, can characterize people that have medically severe suicide attempts, that's a pretty good deal so far as risk for suicide. But you look at the next to last line on the list there, 60% of the excess mortality that these people have after this medically severe suicide attempt is not suicide. And so these people, medically severe suicide attempt is the tip of the iceberg for a problem with behavior control that leads to early death. And we need to be able to identify that problem. The problem with focusing on looking at people who have made a medically severe suicide attempt is that we're interested in suicide and we are automatically eliminating 60% of people who are going to commit suicide from the characteristics that we're looking at. So you see the dilemma that we're in. But if we can identify who these people are, we can also identify preventive treatments. So so it's a very important problem. So suicide, another thing about suicide, besides these characteristics, that there is a group of people who seem to be at particularly high risk for it. And this is not a diagnostically specific group of people. The more people look at high suicide risk and risky behavior and who commit suicide, the more people realize that a lot of people who commit suicide do not have a conventional psychiatric diagnosis. Now, it's true that many of them have personality disorders, by the way. So even when we know that somebody is at risk, it is hard to know when they're going to actually attempt suicide. And so this slide just looks at a couple of examples. First example, they looked at a bunch of folks in a catchment area in Britain, which is a country with a healthcare system, and so they have the kind of records that we don't have, except in local health systems in the VA. But anyway, they looked at suicidal behavior in this catchment area, and they found that 72% of the suicide attempts, looking at the records in the patient's charts by the patient's clinicians, were the patient's clinician, looking at it in retrospect, said that the attempt was unpreventable, that there was no difference between that person's behavior the last time he came in for an appointment and compared to the behavior in other appointments that the person came in for. 3/4 of the time, based on clinical observation by the clinician, suicide attempt unpreventable. So they also had blind raters look at the records who weren't involved in the care of that particular patient or anything like that, and they did not know whether they were looking at the record of somebody who had made a suicide attempt after that appointment, and the ones who didn't. And it was exactly the same. Blind record review, around 70% of the time, not predictable. So it's enough to make us rather humble. The time from the first consideration of a specific suicidal act. So maybe somebody has been thinking about, that he's going to shoot himself, and doesn't know exactly when. And he's got himself a gun, and the gun is in the bureau drawer. And the gun may be in the bureau drawer for years. It may be in there for decades. And one day the person is going to take it out. The amount of time that elapses between the person makes the first behavior toward a specific suicidal act and the time that the person actually does it is 10 minutes. Doesn't matter how much time has elapsed since the original plan. 10 minutes. Once somebody decides that they're going to do it, they do it in 10 minutes. So that also is a little humbling. What can you do in 10 minutes? How can we help somebody? And this is, of course, where we have to be thinking. How can we help somebody have a 10-minute strategy? Know that it's going to happen and do something to protect himself. How can somebody tell that this is coming in time to do something about it? Then, using ecological momentary assessment, very elegant. People have looked at changes in suicidal behavior, or at least suicidal thinking. Most of this is suicidal ideation, and also have looked at affect. So one thing that was found was that negative affect and impulsivity is recognized as a very important combination, not just in suicidal behavior, but in a lot of trouble. It's called negative urgency. And EMA showed that suicidal individuals would have increased negative affect first, and then they would develop impulsivity. And so the negative affect leading to impulsivity. We often don't think of impulsivity as being part of negative affect, but that's a very important problem. And people will tell you. You ask them, they'll tell you, and it's not a mystery, and it doesn't seem odd to them at all. This is part of their life. Also, actual suicidal ideation varies rapidly. And again, this was shown by ecological momentary assessment. And so you look at people and you look at things that correlate with suicidal ideation, like hopelessness and anhedonia. And then you look at what happens over time rapidly. Suicidal ideation correlates with those things at baseline. Over the time of observation, over the day, suicidal ideation fluctuates all over the place. and the fluctuations do not have corresponding fluctuations in the hopelessness and so forth. So the suicidal ideation is much more unstable. So this chaotic characteristic of suicidal behavior probably results from the fact that it results from interactions across processes that have different time courses that aren't necessarily linear. And that's what they say chaos is. And so this slide just shows that. And it just mentions that there are long-term things. So there's just wiggly lines up there on top, but that there's long-term things like what kind of personality we're born with, where we live, what race we are, what sex we are, all kinds of things like that are stable over time. They influence suicidal behavior, so they're good test questions, but they don't tell you when it's going to happen. Then there's intermediate things like being in an episode of illness, being in a difficult situation, having suffered a loss, things like that have a shorter time course. And then there's things that have a very short time course, like response to stressors, overstimulation, hyperarousal. And there are some situations and some people where the combination is makes somebody more likely to experience these immediate changes, particularly hyperarousal. And then longer term things that result in short term rapid effects are so-called sensitizing phenomena, like early trauma, early exposure to addictive stimuli, or repeated exposure to either of these two kinds of stimuli over time, are particularly things that we need to watch out for. Also, some recurrent illnesses make you more susceptible. We're going to talk a little bit more about sensitization later. But this defines people who are at risk for the kind of rapid behavior fluctuations that go with suicidal behavior. These sensitized or rapid responses to stimuli, the susceptibility to have them appears to be epigenetic. If a mother, whether it's a woman or whether it's an animal in an experimental study, which is where most of the work is done, experiences an inescapable stressor during pregnancy, the offspring is susceptible to all manner of behavioral problems later. And there is still increased susceptibility in the generation after that. And that's why they think epigenetic. So in terms of emotions, suicide is related to a combination of impulsivity and hopelessness. And it is the combination of these two that makes things particularly treacherous. And you can't say that a suicidal act is impulsive or it's not. There's always a little thread of impulsivity in a suicidal act, sometimes not much, sometimes a lot. You can't say that a suicide attempt is entirely due to hopelessness or not. These two types of, I guess, emotion is the best word, interact. And the more severe one of these is, the less you have to have of the other one. And they can both fluctuate. So what we really have to watch out for is when there's something, so somebody is depressed, if impulsivity or hyperarousal or activation crops up in an episode of depression, that is dangerous. Likewise, if somebody is hyperactive or impulsive or manic and hopelessness or some related emotion crops up, that is dangerous, much more dangerous than it would be if the person was not impulsive, just like the impulsivity is much more dangerous than it would be if the person was not depressed. Activated depression, therefore, is a very important part of psychiatry. It's not part of any particular diagnosis. You don't have to have major depressive disorder to have this. You don't have to have bipolar disorder to have it. You don't have to have schizoaffective disorder. You don't have to have borderline personality disorder, etc. A lot of psychiatric syndromes can cause it. We're looking at mood lability. We're looking at mixed states of affective disorders, but it crosses DSM categories. Pharmacological things can cause activated depression. Prescribed medicines can do it. That's the trouble with antidepressants in adolescents. They can take a depression and they cause activation faster than they cause the depression to get better. So if you're 18 years old and you have bipolar disorder and the diagnosis has been missed, which it so easily is when you're younger, and you're given an antidepressant, you are susceptible to experiencing activated depression before you get better. And that is why when people looked at the relationship between antidepressants and suicide, they found it stronger in young people, adolescents, and young adults. So anyway, so pharmacological things can be prescribed medicines, can be antidepressants. They can also be anything else that can be activating if they get to the wrong patient. They can be decongestants, for example. Also can be self-treatment, including substance use disorders. And there can be addictions that are pharmacological, that produce behavioral sensitization, and there can also be addictions that are non-pharmacological. And in a way, the brain sees them as all being the same thing. They see the stimulus that is addictive as being somehow related to survival. And the brain responds to those stimuli with the same kind of arousal, turning on catecholamines and stuff as it would if survival was threatened. And they also respond to the reward as if the reward is necessary to live. So that's a very treacherous thing about addictions, is that is easy for me to sit here and say everything is blown out of proportion, but it's not blown out of proportion if you're in that situation. Then environmental situations can also cause activated depression. Overstimulation, and some people are more sensitive to this than others are. Stressors, especially if the person has experienced earlier trauma or earlier addiction. Somebody is more likely to have exaggerated behavioral responses to stressors. And then, of course, depression plus impulsivity is negative urgency. And that is something that we need to teach our patients to watch out for, because it boils down, these things can happen fast. The patient needs to learn how to recognize things and where they came from, and people who are with the patient need to learn to recognize them as well. So we're going to talk about impulsivity a little bit. Impulsivity means that you can't think about something before you do it. You can't conform your behavior to its context. And there are a lot of other ways to look at it, but I think that's what it is. And it's a failure of feedback systems that normally operate during the initial half a second after a stimulus. About a quarter of a second after a stimulus, you start getting consciously aware of it, maybe 200 milliseconds, somewhere along there. Gets into the right sensory cortex in about 300 milliseconds. But the things in the brain that you can measure neurophysiologically in people who are impulsive start going wrong within 50 milliseconds after the stimulus. So you have to find some way to short circuit this. No specific behavior is impulsive. Anything can be, the same thing can be impulsive or non-impulsive. It is the context that determines whether it's impulsive or not. Impulsivity is not poor judgment. Impulsivity is no judgment. Impulsivity short circuits judgment. And unfortunately, if the more impulsive somebody is, the less their judgment is, because they don't get to use it. If you don't get to use it, it atrophies. So impulsivity, there's trait impulsivity. It's the impulsivity that somebody has all the time, and their attitudes and whatnot, even if they aren't doing anything wild. Like the Barrett Impulsiveness Scale is the most established measure for this. It is associated with arousal, and it is related to arousal in a nonlinear, somewhat treacherous manner. Action impulsivity is what the name implies. You can't relate action to its context. Choice impulsivity is when if you've got a choice between waiting for something good and taking anything right now, you'll take the right now and you can't wait. And so those are kind of the three ways that impulsivity is looked at. They're all related to suicide. This slide basically shows that impulsivity and risk-taking are different. I also just like to have a mountain to look at occasionally, and so here it is. So this is the Matterhorn, and the first modern European to climb the Matterhorn wrote, beautifully about it. Courage and strength are not without prudence. A momentary negligence may destroy the happiness of a lifetime. There it is. So,
Dr. Swann, before you move on, could you also comment on a few things? First of all, how does impulsivity regulation? I assume all of us have some level of impulsivity.
Of course.
But we probably learn to regulate it or identify it. And that behavior or that trait, I assume, gets better with age. Is that at what age generally people tend to learn to control it better for normal folks?
Okay, we're going to be the next slides are going to be starting into that question.
Okay, I'll wait.
Impulsivity starts to reduce during early adulthood. The prefrontal cortex is kind of finished being myelinated, usually during the early 20s. And then impulsivity starts to gradually reduce instead of increasing. And that's important because if your first exposure, for example, to alcohol or drugs or anything like that is after that, then it's much less likely to cause problems than it is if it's before. However, impulsivity continues to be a problem pretty much at all ages. And then there's a time when our protections against impulsivity, our compensations begin to weaken, and it starts to get more costly again, even though it seems to be smaller. But in general, reaction times tend to get slower, and most measures of impulsivity correlate negatively with age once you get out of the early 20s. So this slide shows what happens if you take non-impulsive, regular people mostly these folks are in their 20s and 30s. They were given yohimbine, which is an alpha-2 noradrenergic antagonist, which means it blocks the negative feedback system that controls norepinephrine release. And so this measured their performance on a computer task that measures action impulsivity. And you can see that as the dose went up of yohimbine, they got more impulsive on the computer task. And we're going to be looking at this computer task in other contexts. And so, but this impulsivity, this action impulsivity is strongly related to just about any kind of behavior that we're interested in somebody being able to develop better regulation of. So you look at this and think, man, all we have to do is give somebody a laptop, have them carry the laptop around, and occasionally, especially if they're feeling edgy, they can give themselves the immediate memory task and see how they do. That's one way to do it. So the next slide, this is the same people after getting yohimbine. Instead of measuring their score on the computer task, this is measuring their score on the internal state scale activation factor. The internal state scale is a very straightforward self-rating scale that was developed by Mark Bauer in Rhode Island because everybody said manics don't have insight. And so there's no use having a self-rating scale for manics. And Mark said, no, all of our self-rating scales are written in diagnostic criteria language. If you ask somebody questions in their own language, they'll give you an answer. And so he designed the scale, the activation scale, was questions like, I forget, I feel jazzed up inside, things like that. And it turns out that these people got the yohimbine and their activation scale scores went right up. And so what that tells us is that when somebody is at risk for behavior control problems, they can recognize it. You can recognize risky internal states. And so people can learn to recognize what for them are risky internal states and know what to do when they recognize it and not wait for the consequences, because you've got this rather small time margin to do that. So in terms of impulsivity and suicide, just briefly, we looked at people who had shot themselves and were brought in by life flight. And a substantial number of them, oddly enough, weren't expecting to die, even though they used a deadly method. Even the ones who were expecting to die, there was a little twinge of something. I talked to this guy at Herman. He had shot himself in the chest. He was a former Army Ranger. So I said, "Why did you shoot yourself in the chest?" He said, "If you shoot yourself in the head, it's a crapshoot. You don't know what's going to happen. The bullet goes, a little bit one way or the next, and it's the difference between dying and being a vegetable. But I know that if I shoot myself in the chest, I know which ribs I can aim between. I know the angle I can go at. I can get the aorta. I can get, I can get the lungs. I can get the heart. I can get everything." So I said, "Why are you alive?" And he said, "I flinched." So lucky for him. And firearm deaths are a very important part of suicide. Half of people who kill themselves shoot themselves. About 2/3 of people, or a little more, who are murdered are shot. And so what that means is that twice as many shoot themselves as are shot by other people. Just an aside. We looked at a case control study of people who had made severe suicide attempts, and look there. I think the most interesting thing was the relationship between hopelessness and depression. That the more impulsive people were, the less hopelessness was related to depression. You could have elevated hopelessness according to the Beck hopelessness scale and not have a depression score that was higher than controls from the community. And if you look at the characteristics of impulsivity, the lack of future sense, the intolerance of complexity, you realize that the Barrett impulsiveness scale has hopelessness built right into it, and you don't need to be depressed. So there's that. And then we looked at people with bipolar disorder, which has a high rate of suicide and all these problems. And so there, we gave these people the same test that I mentioned before, that the controls got, who did these impulsivity scores and had their MHPG measured and stuff like that. And so this is what happened. And so this is their scores on the same thing. So the higher this is, the more impulsive they were. These people all had bipolar disorder. They were stable. If they had made a suicide attempt, it had been at least a year since the suicide attempt happened. So, so here's this thing down here. They had never made a suicide attempt, at least didn't say that they had, probably had. And then here's these people who really didn't score much higher, who had made a suicide attempt that was not medically severe. These people had made a medically severe suicide attempt. And so this is a test that is supposed to be a test of state-dependent impulsivity. They made a suicide attempt a year ago, and now they're stable, and they still score very high on this test. And so that tells us that some people are walking around looking stable, etc., but that right below the surface is this potential for action impulsivity. And I think that is one thing that makes suicide risk so treacherous and the short-term prediction so difficult. And this just shows that their reaction times got faster. So impulsive action was increased and reaction time was accelerated in people that had medically severe suicide attempts. They had been stable for at least a year. Action impulsivity looks like a latent trait, which is also part of behavioral sensitization, that's related to susceptibility for a medically severe suicide attempt. A latent trait is something that's always there waiting to be waked up, but you can't see it. And this slide, we're just gonna zoom past because I'm a little concerned about time. but it refers to the fact that impulsivity is necessary to survive. There's a reason why we have impulsivity in our brains after all these generations when natural selection could have gotten rid of it. Sometimes we have to be able to respond quickly to a stimulus. Sometimes we don't have time to think. Conscious thinking is clunky and we can't always afford it. But what happens with sensitization to stressors or to addictive stimuli or to certain psychiatric disorders is that this response becomes generalized and occurs in reaction to anything that transiently increases arousal, hyperarousal. So the brain responds analogously to things that are stressful or reinforcing because they're both related to survival. Repeated highly salient stimuli elicit sensitized responses, and stressful and rewarding sensitizing stimuli can cross-sensitize. People who have been exposed to addictive stimuli are more sensitive to stressors. People who have had early trauma are more susceptible to addictions. Both groups are more susceptible to suicidal behavior. So this, we actually talked about the top part of this slide already, but the bottom part is interesting to me. So this was Voltaire writing about suicide. The man who in a fit of melancholy, see, he really got it. The man who in a fit of melancholy kills himself today would have wished to live had he waited a week. But people don't have just one fit of melancholy. Some people may not have any in their whole lifetimes. I think most people are going to have one sooner or later. Some people have repeated fits of melancholy, and they're susceptible to fits of melancholy. And these are the people that we need to identify as at high risk for suicidal or similar behavior. So Voltaire should have sat in. The DSM-5 has recently started to wrestle with the idea that severe suicide risk is not specific to any psychiatric diagnosis. And so Maria Oquendo and I think, subcommittee came up with 2 diagnostic categories that were not considered diagnostic categories, that are official, like major depressive disorder, but were considered entities that need further attention. Those aren't the exact words, but that'll do. There were 2 of them. One of them was something called suicidal behavior disorder. This was people who had made a severe suicide attempt within 2 years and had certain other characteristics. And so you could argue that, well, okay, according to Voltaire, this is somebody who is susceptible to fits of melancholy. And then the other disorder they came up with, which they considered a totally separate disorder, was suicide crisis syndrome, which is the same thing as Voltaire was talking about when he talked about a fit of melancholy. And of course, these 2 things probably largely go together, that some people are susceptible to fits of melancholy for whatever reason, and that when somebody has a fit of melancholy, that's suicide crisis syndrome. Voltaire got it better than DSM-5, because DSM-5 said that you got to have a suicide attempt to have suicidal behavior disorder. And we know that 50 or 60% at least of suicides were the first attempt. So if we require that somebody had a suicide attempt in the past, we're throwing away 2/3 of suicides. So far as trying to determine suicide risk, we got to learn from these people who made medically severe suicide attempts so that we can see what it is about these people that we can also identify and look at in people who have not made a suicide attempt yet, because those are the people we need to eventually focus on. And and then in terms of specificity, of course, the other thing is that, what Voltaire would have called suicide crisis syndrome, people who have that, and people therefore who have suicidal behavior disorder, it's not just suicide. A lot of these people die from other causes that are related to poor action control. So this is a disorder of action control related to things that have happened in the past and so forth sometimes, related sometimes to other psychiatric or medical conditions. And it predicts premature death. And the most alarming and greatest single cause of that is suicide. But it's more than just suicide that we're looking for. So then this slide, I think, I need to look at my clock here because my computer doesn't have the time on it. So we have just a few minutes. And so I want to buzz through a couple of things so we have time to discuss things. So this shows how, different types of stressors cause trouble later. And there is an example on this slide of an inescapable stressor, which predisposes toward post-traumatic stress disorder and all kinds of other problems. And of course, that unfortunate event is happening to this creature here who does not have legs. On the other hand, people who can learn to escape from a stressor develop resilience. So as long as she doesn't fall down, she has a chance to develop resilience from this, to learn that she can escape from a difficult stressor. I like the expression in the eyes of the snake. The reptile suffered, the cartoonist here knew something. The reptile suffered deep emotional scars. Stress, trauma-related things really set things up for the kind of problems that we are dealing with. Addictive problems also do, and addictive and trauma-related problems are related, analogous in terms of their long-term effects on the brain. One very important thing for us to learn about people that we evaluate is bad things that happened to them before, especially bad things that happened when they were kids. And if we can know about bad things that happened to their mothers before they were born, or their fathers before they were conceived, that would be useful. But we can't usually get that kind of information, but we can find out about bad things that happened to somebody earlier in their life, and that will help us know what to expect. So sensitization, we're going to buzz through here now. You can read the slide later. The development of sensitization is when you're exposed to an inescapable stressor, an addictive stimulus. The same neurochemical things happen during affective episodes, etc. And the expression of sensitization is when you're exposed to something like that stimulus again, and you have the exaggerated behavioral response, which is usually related to stress-induced hyperarousal. And the interesting thing to me about this is that between somebody who has been exposed to the stimulus, but has not, and developed sensitization to it, but they have not, they are not experiencing sensitization by re-exposure to it, they have this latent characteristic that they've been sensitized. So in some respects, their brain is just waiting for trouble. It's like those people with bipolar disorder in that slide that had this high so-called state impulsivity, even though they were stable and doing fine. So to prevent sensitization is difficult to do, because by the time we see people, it's too late for the most part. Whatever's happened, happened. But more practical is to see who is at risk. And then we can say, how can we prevent the expression of sensitization? That's what we're basically trying to do medically. So this I've sort of talked about more than once, so we can pass it. This shows the transmitters that are involved, interestingly enough. Nicotine, smoking cigarettes basically doubles the risk of death by suicide. So if you smoke more than about a half pack a day, it's a good idea to quit. glutamate receptors. It turns out that things that block glutamate receptors, like ketamine-like drugs, can be very useful in blocking the expression of behavioral sensitization. So there's interesting things here. And then sensitization is required for PTSD. It's required for addiction. It's not required for things like bipolar disorder and borderline and depression and stuff. But these folks are more susceptible to it, and it can make those illnesses much worse. So to help somebody be resilient to sensitization, there's things that can be done, many of which are educational and social things. Learning to reframe stressors. I can think of very few things that could possibly be more valuable to teach in school than teach somebody how to reframe stressors. I think they're worth putting off algebra for a year to learn that. Increased social interactions, as long as they're not toxic. Physical activity. I'm not saying exercise. Exercise makes people compulsive and whatnot, but increased physical activity helps resilience to anything. It's tremendously beneficial for anything that has to do with how the brain works. A lot of research with enriched environments, some in people, mostly in animals. Stress inoculation. Being totally sheltered is a bad thing, unless for some reason you're somebody who requires that. It is better to learn that you can handle trouble. This just shows that people that had high scores on the childhood trauma questionnaire, that contributed highly significantly to their trait impulsivity. This shows that in bipolar disorder, people who were not manic did not have high action impulsivity generally, but they did if they had a history of addiction. So this basically, and you can read this, but it shows the factors that lead to a medically serious suicide attempt, and then the consequences of a medically severe suicide attempt, and how when a person survives it, it still launches a person back into a cycle. And I recommend reading the trial, reading the slide. And then, because I there's 2 slides about a study that we're doing right now, which Dr. Mukadam is familiar with, where what we're trying to do is to say, okay, one way that people study the prevention of suicide is that you give somebody whatever you're giving them and you wait for bad things to happen, and you have to treat a lot of people, and mostly nothing bad happens to most of them. And a lot of time, so it's a very cumbersome way to do things. And so instead, what we're trying to do is to identify people who are basically people who are susceptible to fits of melancholy. And so we're looking for people who have made a medically severe suicide attempt, but they're stable from it. And then matching them up with people that have the same diagnosis. And then looking at these kind of characteristics, histories of sensitizing things that have happened to them, measurements of action, impulsivity, and so forth, and comparing them to people who are diagnostically more or less matched to them, to see, okay, what are some characteristics that can help us to recognize people who are susceptible to fits of melancholy. And then for the next part, we give a treatment, not for long enough to see whether it prevents suicide, but just for long enough to see whether it affects these characteristics. So it's practical. And in this study, we're giving lithium. But I think that the next thing is to say, well, how about the study, looking at something that blocks short-term suicidal behavior? Ketamine or something like that would be the obvious candidate for that. It blocks excitatory amino acid transmission, which is required for sensitization. It's been shown to reduce suicidal ideation fairly quickly, even when it doesn't necessarily reduce depression. So because of its role in sensitization, it'd be very useful to see whether ketamine or something like it, because ketamine does have its problems, would be able to ameliorate some of these whatever differences get found between people who are at high risk for suicide and people who aren't. And so let's see, this we can go past. So action is regulated by long and short-term things that interact, which makes things very noisy and complicated, but it also makes life very rich. Suicide is an example of what can go wrong with this, that the susceptibility to action impulsivity and stress-related arousal may underlie suicidal behavior. Not cause it, but it's one of the things that's going on that's a rate-limiting step for it. If we can identify these and then find relevant pharmacological and non-pharmacological strategies, then perhaps we can do something that can prevent suicide without waiting for awful things to happen. So, summary, there's a lot of people that are mixed up into the things that we're working on here, including Ben Taub, the VA, Menningers, Baylor, and so forth. But I'd like to thank you very much for your attention. And let's see, there Ashutosh raised his hand. That might have been the question that he already asked. But if anybody has any questions and we have time to talk about them, this is the time to do it. Otherwise, you can also feel free to send me an email.
Dr. Swann, I have another question. This is Ashutosh.
Oh, good.
Yeah. So first of all, thanks for the great talk. We learned a lot. Suicide being such an adverse event is the outcome. Are there other, I guess, medical outcomes which are impacted by low or high impulsivity?
There
Perhaps
are a
chronic
lot.
diseases. Okay. Could you give us some of those examples too, so that they may be appearing in other areas we all work in, but just don't recognize it?
Yeah, I think that skipping right off the top would be cardiovascular illnesses, inflammatory, inflammation-related conditions.
And in that case, is the pathways of, for example, is smoking, for example, considered to be associated with higher impulsivity?
Yes, it doesn't matter whether you have a psychiatric disorder or not. In fact, there's a lot of data about smoking and suicide. In the general population, it doubles the risk of suicide after you correct for demographic things and stuff like that. And I can actually send you a review of that some of our gang did. I think it's fair to say we were all somewhat surprised. And it's nothing magic about smoking. You can explain it because of what smoking does or what nicotine does to the regulation of behavior and to sensitization. And smoking is a diabolically clever and efficient way to get nicotine to the brain. There are very few drug delivery systems like it, as long as the drug you're trying to deliver is relatively stable to heat. 15 seconds, and you've got effective levels of nicotine in the brain. A minute or two and it's gone, so you're pumping some more. I mean, it's amazing. And of course, smoking interacts with many other illnesses.
Right.
And this isn't the only thing, of course, which is bad about smoking, but it's something which compounds the toxicity of smoking to the lungs and to the vascular system.
And then could you also just comment? I know we probably asking all the questions, so I apologize for that. That how behaviors like smoking or maybe other addictive behaviors then continue to increase impulsivity. Is it, let's say, people who smoke for 1 year but then quit, do they tend to generally go lower on impulsivity scores and versus folks who just continue to smoke?
Yes. If you quit smoking, things may not go back entirely to what they were like before, but if you quit smoking, behavioral problems will become better than they were when you were smoking. For example, suicide risk is significantly lower in former smokers than it is in people who have continued to smoke. So things don't entirely go back, and of course, some of the damage that's been done to the lungs and stuff has been done, but many of the behavioral effects of nicotine are dependent on smoking. Of course, smoking also produces sensitization to other addictions and to stressors, and that takes a longer time to go away, but at least it starts to decay when somebody quits smoking. So quitting smoking is a very judicious thing to do. You know how the brain works. If you're interested in reading about suicide in terms of the effects of suicidal behavior on the people who did it, the Golden Gate Bridge, 2,000 people have jumped off the Golden Gate Bridge, and 20 survived. And those 20 people, some of them have been interviewed out the wazoo, and they have amazing things to say. And you can Google Golden Gate Bridge jumpers, and you can get some of these interviews to read, and you can find references to reviews, collections of narratives about people that jumped off the Golden Gate Bridge. It's an amazing thing. And
Dr. Swann,
yeah,
Dr. Swann, thank you so much. We are very, very happy to have finally had a combined presentation with the engineering team at Rice. I want to thank you for this. B, I want to point out that we also want to think about impulsivity as a precursor for other behaviors. So suicide is a very serious behavior. But I think that if you're in college, it can be very hard for you not to know somebody who's, for example, cut their wrist or threatened to do something. And it sounds very bad, even though cutting your wrist is probably not going to kill you, but it is scary. And so besides the thought process, how do I even get there as a person? There's also the what parameters can I measure? So that's one example that would be directly applicable to the group we're talking to. The other examples would include things like overeating, overspending. So any behavior that you can think of as requiring some internal calibration would be hit by the dimensions that Dr. Swann just mentioned.
That's
the
right.
difficulty is how do I measure? Right. How do we measure this? And how do we translate it to math? So you had one really good slide that says, how do we get to fits of melancholy? And I was thinking this sums up exactly the watershed area between our two fields, mental health and ECE. Because how do we measure that stuff? First, we have to define it, then we have to find ways to measure it.
That's right.
Can you comment on that?
Well, for one thing, that's why I'm really glad that we're having these meetings. And you're right, there's a whole class because when you look at how the brain is developed, it wasn't planned afterwards to do something. It developed in response to stimuli and changes and so forth. And so we have a broad class of ways that the brain can have trouble adapting to stimuli that are related to survival, and civilization has gotten complicated, and so survival related stimuli are complicated, and so being sensitized to inescapable stressors or trauma, well, of course, but then we have and then being sensitized to substances, but we have very analogous things that go on with gambling and that go on with eating. I'd say those are kind of the big two among addictions that are being studied right now, but you can find plenty of others. And it's very analogous. It's the same processes in the brain that are involved in addiction to cocaine, or that are involved in having had some terrible thing happen to somebody when they were young. It's many of the same circuits. It's very analogous. And then sitting at one end, the tip of the iceberg is like suicide. And then between, for us and our patients and stuff in life, there's a whole lot of stuff between here and there that we need to understand. And sensitized behavior, I think, in terms of understanding it mathematically, is a fascinating problem because it's latent and it's nonlinear, and it's when you try to measure it with wearable devices, you run into a sort of a Heisenberg problem, because the more you ask questions, the less good the answers are. So what are you gonna measure instead? And I think that question, what are you gonna measure instead? What can you measure about how the body or the brain is working, which relates to these traits? I think that's an amazing question.
I think that's wonderful. Thank you so much. And on this lovely note, we should end because it's 6 minutes after 1. Does anybody else have any questions? Nope. I'm getting private text in the chat saying that this was lovely. Thank you so much, Dr. Swann. It was wonderful to have you. Thank you,
and you have my
attending.
email address, right?
Yes. And Aki has it too. So
send around my email address. Anybody that has a question, welcome to send me an email.
Absolutely. Thank you.
Okay,
Bye.
very welcome. Bye. Y'all have a good day.
Bye.